Hi, everyone. Welcome to the IFAM seminar series. I'm Dr. Tara Legou. I'm the director of the Center for Health Services and Outcomes Research in the Institute for Public Health and Medicine. Every Thursday, as many of you know, we host a public health researcher, and today we are joined by Dr. Patty Lee King. Dr. King has a PhD in social work and is a research assistant professor in the Department of Medical Social Sciences and is also the state project director of the Illinois Perinatal Quality Collaborative, which is housed in the Center for Health Services and Outcomes Research. ILPQC is a statewide network of hospital teams, perinatal clinicians, patients, public health leaders, and policymakers who are committed to improving obstetric and neonatal care to reduce disparities in maternal and infant morbidity and mortality, and to improve outcomes for all birthing people and newborns. Dr. King has over 20 years of experience in leading quality improvement and program development initiatives, implementation, and evaluation in local and national settings, and has a focus on health equity, maternal and child health, and mental health. Before I pass it along, please, one housekeeping note. We have time at the end for questions, but rather than putting questions into the chat, please use the Q&A function on the far right of your sort of option screen at the bottom of your screen there. All right, and so take it away, Dr. King. Thank you so much for joining us today.
Thank you so much, Dr. Legou, and welcome and thank you to everyone who's joining us here today. I'm really grateful to IFAM for this opportunity to share the work of the Illinois Perinatal Quality Collaborative and touch on opportunities for you to engage in statewide quality improvement. I hope there'll be a little something for everyone. So I am lucky to be a member of a fantastic team, including my colleagues here, pictured here. They work across Northwestern University, North Shore University Health System, Evanston Hospital, Lurie Children's Hospital, and St. Louis University. And we have a whole state full of clinicians and public health people working as members of the Perinatal Quality Collaborative across the state. So I promised throughout this talk, I'm going to try to, as a non-clinician myself, working in a clinical world, I'm going to try to reduce my jargon and make things accessible to everybody. And this is my first attempt, but really just talking about the importance of what ILPQC does. So this was mentioned in the overview, but hopefully just to repeat, we're a network, so a bunch of hospitals, doctors, nurses, patients, public health leaders working together that do care in Illinois. And we work together on projects to improve healthcare for birthing people and newborns, focused on reducing disparities in health problems and death, and improving outcomes for all birthing people and newborns overall. So just a little overview of what we're going to talk about today. We have to do a little bit of level setting and review some key perinatal health outcome measures that I hope will be helpful in orienting our work and why we do this. Also talk about the role of perinatal quality collaboratives in general, getting pretty quickly to ILPQC's approach as a key example. Then we're going to try to make time for highlights on some current initiatives with some select data. This is the bullet where, like I said, I try to be focused and make the information as accessible as possible, given how little context I can give. But I hope it'll be at least enough to whet appetites, and you can reach out for more information if you'd like to discuss further. And then we'll wrap up with clinician and stakeholder engagement opportunities to get involved. So let's start with this review of key perinatal health outcome measures that I promised. So most pregnancies are uncomplicated and do result in a healthy birthing person and newborn. There are about 3.7 million births in the United States annually, give or take. And then within that, severe maternal morbidity, which we'll define soon, that's birthing people getting quite sick with specific conditions, affects 50 to 60,000 birthing people in a year. And then maternal mortality, which is death, affects about 650 to 750 birthing people in a year. Many cases of severe maternal morbidity and mortality after review are deemed to be preventable, and that's where we come in. So again, a little bit of level setting. This is to show kind of how the measures of death, so mortality among birthing people relate. You'll hear different ones throughout this presentation because different groups use different measures. So we're going to start from the inside out. So with the gray Maternal mortality includes deaths during pregnancy and up to 42 days postpartum that are related to pregnancy reported as maternal deaths per 100,000 live births. This is what's used by the Centers for Disease Control and Prevention and the World Health Organization. It excludes deaths that are considered accidental or things including overdose deaths. The next is pregnancy. So medium blue, next out is pregnancy associated mortality. This is deaths during pregnancy and up to 1 year postpartum. And then pregnancy related mortality. I'm sorry, I'm actually not going in the right order. So pregnancy related mortality are deaths within the first year postpartum, in pregnancy, first year postpartum, that are specifically considered related to the pregnancy itself. And then the dark blue going out is pregnancy associated mortality. And this is deaths during pregnancy and up to 1 year postpartum, inclusive of all deaths. Both of the measures in blue are used by the Department of Public Health in Illinois, and I'll be talking about them, which is why I wanted to define these. These do include deaths by homicide, suicide, and drug overdose. So two differences, the amount of time and the deaths included. All right, so getting into some data. Again, these are sample graphs. We could do a whole talk on each of these topics. We're not going to, we don't have the time. In this first graph, this is looking at the Global Burden of Disease study. It was published in the Lancet a few years back. We see that US stands apart from other industrialized nations in maternal mortality with higher maternal deaths. And then while we see other nations decreasing in that past 30 years, we see that the US maternal mortality rate increased in that time. And this difference between the US and other nations, it continues looking at 2018 data from other sources. The difference continues. Here in another graph, again, looking at US maternal mortality, contributing to the high US maternal mortality rate is mortality rate among Black and Indigenous Americans who are 2 to 3 times more likely to die each year as a result of pregnancy or its complications. And these racial disparities have persisted in the United States over time, and recent data pictured here from the CDC using vital records data from 2018 to 2020 shows the current racial disparities in maternal mortality between Blacks and other racial and ethnic groups. Okay, now we're taking it to Illinois, still looking at mortality among birthing people, specifically pregnancy-associated mortality. This is all deaths during pregnancy or the year postpartum. So this is from the Department of Public Health. So we see an increase in the pregnancy-associated mortality ratio over time in the first figure. And then racial disparities between Black and white birthing people here is consistent in Illinois with national data. Just to make sure as we move on to the next, we've been talking about deaths in pregnancy and the year and 42 days to a year following. And then next we're going to look at morbidity. So in the inverted triangle slide we looked at earlier, we saw severe maternal morbidity was above mortality. So it happens more often. And it's an unexpected outcome of labor and delivery that results in significant short or long-term consequences to a birthing person's health. Like mortality, this is something we want to reduce. And from reviews, we know that many cases of severe maternal morbidity can be prevented. We mentioned that earlier as well. So these are just some identifiers of severe maternal morbidity. They include specific diagnoses related to heart, lung, blood, other infections, and then as well as some procedures also listed. This is not the complete list. The full list is available from the CDC. So looking at morbidity in Illinois, we know that severe maternal morbidity, which includes stroke and ICU admissions here, is more than double among Black birthing people compared to white birthing people, and is worse for all other racial and ethnic groups compared to whites. And then in Illinois, part of a group called the Maternal Mortality Review Committee does look at the causes of deaths. And for the subset of these deaths that are considered pregnancy related, so if the person wasn't pregnant, the person's pregnancy led to them happening, found that mental health disorders, including substance use disorder, was the most common cause of death, followed by chronic conditions, hemorrhage, and hypertension. Okay, So now we're going to just quickly talk about infant mortality. So we're going from maternal outcomes to infant outcomes because our work covers both. The infant mortality rate is reported as the number of deaths per 1,000 live births. And it shows that the US, so this is a similar narrative to what we looked at for maternal mortality. The US has a higher infant mortality rate than other developed nations. And in the second graph here, the current rate of infant mortality in the US is 5.6 deaths per 1,000 live births. That exceeds the healthy people goal, which is a goal we create nationally, of 5.0 deaths per 1,000 live births. Racial disparities are clear here, with non-Hispanic Black and Native Hawaiian or other Pacific Islander infants twice as likely to die as white infants, and American Indian or Alaskan Native infants over 1.5 times as likely to die. The Black-white racial disparity in infant mortality has existed for a very long time and has increased over time. Okay, Illinois data, infant death. We see the March of Dimes here. They have a data set called Peristats. Shows that the Illinois infant mortality rate in 2019 was 5.7 per 1,000 live births, had declined 17% for the 10 years, or during the 10 years previous. They found these deaths in Illinois when a review of Illinois infant deaths done by the Department of Public Health in a 2018 report, or actually 2020 report based on 2018 data, found that these deaths are, the majority of these deaths fall into one of these 4 categories: prematurity or fetal malnutrition, death from birth defects, sudden unexpected death, and death from pregnancy or delivery complications. And in the second figure, we see that despite some improvements in the state's overall infant mortality rate, that there are racial disparities, with infants born to Black birthing people nearly 3 times as likely to die as infants born to white. And we see that the Black infant mortality rate is the only not meeting the goal, and we haven't seen or achieved improvement in the Black infant mortality rate since 2008. Okay, so moving right along. What do perinatal quality collaboratives have to do with it, and how does ILPQC do their work? So perinatal quality collaboratives are a Centers for Disease and Control and Prevention, CDC, recognized strategy to reduce maternal and infant morbidity and mortality at the population level. And this is a little bit of a schematic about how that works. So there are groups at local and state levels that review deaths, maternal mortality review committees, fetal infant mortality reviews, other Department of Public Health processes that review data to really understand the factors involved in maternal and newborn deaths. And they provide a lot of insight. And then the perinatal quality collaboratives then use that information and quality improvement science and national guidelines from groups listed at the bottom. So Alliance for Innovation on Maternal Health, ACOG, American College of Obstetricians and Gynecologists, Society of Maternal Fetal Medicine, American Academy of Pediatrics, and use that information together to implement quality improvement efforts and improve care for birthing people and newborns. On the right are just listed examples of initiatives that ILPQC has done that were directly informed by these data reviews and insights from the public health reviews and processes. So I described previously how much review of maternal and newborn deaths informs our work. There are other factors that we use, including buy-in from our advisory work groups that are also informed by those same review processes. We work closely with a network of perinatal providers that are facilitated through the Department of Public Health, the regionalized perinatal system, to support our work. We also survey our hospitals based on their interests and priorities, and invite other perinatal quality collaborative leaders to share their learnings and strategies from their implementation of similar initiatives to inform our plans. And then we discuss and vote on initiatives with all of our members, providers, nurses, public health leaders before moving forward. This really helps us be successful and everybody engaging in the work going forward. So briefly, there are perinatal quality collaboratives either now, there, or in development in all 50 states of the United States. The light green ones are the ones that are in development. The other colors all indicate that there is a PQC there. Now, all PQCs are unique in their structure. So I don't mean to tell the ILPQC story as the only way PQCs work, but I do think it touches on a lot of the essential components and is what we're working with in Illinois, which many of us are located in. So ILPQC, I'm going to go through this quickly because some of this recaps points made earlier. We are a collaborative of physicians, nurses, hospital teams, patients, public health, and community stakeholders. We implement data-driven evidence-based practices to improve maternal and infant outcomes using quality improvement science. We have over 95% of birthing hospitals and neonatal intensive care units participating in an initiative at this time. And we have obstetric and neonatal advisory work group participation across our state, meaning members and representatives from across the state are providing input at another level. This is just a little bit of a diagram that I won't get too into about how we're structured, but we get input from our stakeholders and advisors through our leadership group, meets monthly. We get input, take that information, bring it to our advisory groups, which give us input monthly. And then we meet with our OB teams and our neonatal teams monthly on each initiative to help drive the work forward. So we use a framework for engaging hospital teams at ILPQC. We do have a paper available on that if you're interested to learn more about it. I'm not going to get to it in great detail, but just to highlight, because it talks about how you can get engaged. It helps build the foundation for how you can get engaged later. We really work to engage hospitals to create an environment of improvement. We motivate those hospital teams to facilitate change at their hospital on an ongoing basis. We are always learning across the whole course of an initiative how to do that. And then we support hospital teams with collaborative learning opportunities, data, and QI support to help them achieve our initiative aims. So the first step is really building a team. The team, ILPQC is here. I'm here telling an ILPQC story. The story starts with people working in hospitals as doctors and nurses and staff. And so how we get those teams to form at the hospital is through recruitment, through that regionalized perinatal system, through the Department of Public Health in Illinois that we're so lucky to have and is a great collaborator. And then we also now, after being around for almost 9 years, we have extensive contact lists of all the people that work in the hospitals that have participated in quality improvement in the past. We have them submit rosters online and identify their responsibilities and commit to certain activities. And then we have them choose team lead, which is usually, which can be a distinct person or can be, they also required physician and nurse champions. And then different initiatives have interdisciplinary team members specific to the initiative. So just a little bit about, again, in one slide, how we do our work, so our approach. I've mentioned these more briefly, but just as a foundation, we, in addition to supporting teams develop, as I described on the previous slide, we do provide opportunities for collaborative learning across hospitals through in-person events, which happen twice annually and monthly via web-based meetings. We've been doing that before Zoom became everywhere. We also have created a rapid response data system, which is what we call our ILPQC data system, where hospital teams work to abstract data, collect data, submit it into a web-based form, and then they get reports that help them look at their progress over time and compare to other hospitals on our initiative measures. And then we also have quality improvement support that includes individual. Sorry, I've lost control of my mouse here for some reason. This isn't going to be good. We'll see if we can work with this. Sorry, having some technical difficulties today, everyone. We have so quality improvement support really is to provide one-on-one counseling and strategy making, creating plans for quality improvement, small group discussions and resources for teams. The model for improvement is the diagram on the right. This is from the Institute for Healthcare Improvement. This is kind of our framework, how we do our work. We define aims that are specific, measurable, and can be achieved over time. We develop measures with our teams collaboratively, which include structures, processes, outcomes, and then balancing measures to make sure that no harm is coming in from changes that we're working on. And then our changes are largely facilitated through quite a bit of quality improvement resources that we develop. Now let's see if we can still advance slides. Excellent, we can. Okay, so our ILPQC data system is pictured here. I don't know if the animations will work. Okay, they do. This is like an example of a paper data form that we do create for teams. Often they use it as a tool to pull their data before it's entered. Not always the same people do the tasks. They enter it into a secure REDCap data form, and then they get back reports looking at their data over time in comparison to others. This is just one example from a hypertension initiative. We do this for all of our initiatives. And the hospitals use this to inform their quality improvement team, share with all the clinicians at the hospital to drive their improvement efforts. So here we have a timeline of all of the initiatives we've done to date. We started in 2013 at a conference that was considered our kickoff. In that time, we've held 10 quality improvement initiatives that have been completed. We have 3 currently in progress. I'm going to very briefly talk about what we accomplished in the 3 that are highlighted in yellow, and then also quite briefly talk about what's happening in some of our existing initiatives. And still working here. Okay, a little bit of emphasis. Okay, so let's see if, okay, sorry, one moment. Just gonna see if I can get control of my screen back. Maybe not. Okay, we'll work with it. So here are recent accomplishments. Our maternal hypertension initiative was from 2016 to 2017. 112 hospitals participated in that initiative. There were more birthing hospitals in Illinois at that time, which is why you might see different numbers. I'm going to stick to big picture, but we saw an increase in severe maternal hypertension cases that were treated in 60 minutes or less, which was a key process measure, and a concurrent reduction in severe maternal morbidity during that time that was supported by population level data as well from the Department of Public Health during that time period. The other 2 initiatives are kind of complementary initiatives. It was called the Mothers and Newborns Affected by Opioids Initiative. There was an obstetric initiative with distinct obstetric teams. And then in some hospitals, there was definitely team members working across both. And then Mothers and Newborns Affected by Opioids for the newborns. On the obstetric side, we really focused on universal screening and optimal care. And we saw an increase in the use of universal screening with a validated tool among all birthing people coming in at labor and delivery. And we also saw an increase in the receipt of optimal care for opioid use disorder, which included medication-assisted treatment, recovery treatment services, and Narcan counseling and prescription. And then for the newborn initiative, we saw an increase in breastfeeding rates at discharge and a decrease in the length of newborn pharmacologic treatment. That initiative went from 2018 to 2020. Okay, we'll move on. So now we're going to turn to, again, very brief and potentially the toughest to navigate section where we're going to look at current initiatives and what we're currently working on. I apologize that it is so brief. Please feel free to reach out to us at info@ilpqc.org. I think that information is at the end. Or you can look at our website, ilpqc.org, if you're curious to know more. We'll move ahead. So there are currently 94 hospitals participating in our initiative called Promoting Vaginal Birth. And they're working to support vaginal birth and reduce primary cesareans for optimal maternal and neonatal outcomes. Just again, because we haven't talked in detail about any of these specific cesarean sections, can increase women's risk for serious health problems, including infection, postpartum hemorrhage, and death. And repeat C-section births increase the risk of long-term complications. So we know that we haven't seen a lot of improvement in the rate of what we call an NTSV C-section, which is kind of is a cesarean section among a low-risk first-time birthing person, and that there's a lot of variation among hospitals in this measure, and so there is, which always suggests room for improvement, and that is why we are doing this work. So our aims and goals here is really to get more hospitals among our participating hospitals to be at or below another healthy people goal of less than or equal to 23.6% cesarean delivery rate among those low risk first time birthing people births by December of this year. We're going to do that, focused on highlighting two of the main goals. One is increasing the percent of cesarean section deliveries among NTSV births, which is again those low risk first time births that meet ACOG SMFM criteria for cesarean. So ACOG and SMFM are acronyms for professional groups that help provide guidelines for practice. And then we're also working to increase the percent of physicians and midwives and nurses educated on ACOG SMFM criteria. So things about what the criteria are for cesareans, labor management, strategies in response to labor challenges, protocols for facilitating decision huddles, and decision debriefs. These are all strategies we use in different initiatives, but specific. They're specific in this case to our Promoting Vaginal Birth initiative. Some key strategies that the hospital teams are focusing on here. We really try to, you'll see a lot of me pulling together ideas. We really try to create distinct, actionable strategies and help our teams focus to accomplish what are often very complex changes. So here they're working on identifying those NTSV births and recognizing clinical teams when they are successfully completed. We are also working with teams on educating their clinicians on American College of Obstetrics and Gynecology and Society for Maternal Fetal Medicine. That's that ACOG SMFM acronym again. Criteria for cesareans. So making sure everybody knows the guidelines. Working on implementing cesarean decision checklists and huddles for every cesarean decision-making point. And providing resources to support labor management training and support so that staff can use this information to support vaginal birth with their patients. Unblinding provider data on cesarean section rates within a hospital and sharing it to help create motivation and awareness among their providers. And then making sure that hospitals have access to standardized patient education and that all patients get that education on cesarean delivery and labor management, and then shared decision making so that they're a part of the delivery decision. Okay. So this is just a snapshot of some of our measures. We are not including all of them, although there are quite a few here and they're grouped together. Structure measures are a big part of where we start with initiatives. These are changes that hospitals make that help facilitate process and outcome improvements. Key structure measures here, we can see teams are already making improvement and are making progress we would expect at this point in the initiative with a little less than a year to go. Green means that they have a structure measure in place. So it's the proportion of hospitals in our collaborative that have a structure measure in place. Yellow means that it's the proportion of hospitals that are working on putting a structure measure in place. Red means they're not started on it. So we want to see increasing yellow to increasing green over time. And we can see that a lot of our hospitals are making a lot of progress in making sure education is happening among providers and nurses, that they're implementing standard protocols and processes for induction labor support and addressing fetal heart rate abnormalities. These are things that clinicians need to know to be able to respond as anticipated every time with the right information. EMR integrations, this is electronic medical record integration, that they're incorporating these protocols and processes into their EMR again to help providers do the right thing every time. And then cesarean decision checklists, which is a tool that uses those ACOG SMFM criteria to help clinicians make decisions using the criteria in the moment. Okay, and this is just more progress on more structure measures. We can see what we would expect, increasing green across these structure measures on using decision huddles and debriefs at cesarean sections, sharing decision-making with the patient and tools to do that, implementing standardized patient education and positive messaging, and sharing provider level data. We talked about unblinded data earlier. And then on a key measure here, we're looking at, and this is looking at NTSV C-section rates. This is our outcome measure. What are we trying to achieve? We're trying to help the majority of hospitals get to the Healthy People 2030 goal of NTSV cesareans, which is the red line. And we can see that as of February, which is our we have a little bit of a lag in our data collection due to COVID-19 and the enormous amount of pressure and activity that hospitals have been engaged in outside of quality improvement in addition. But as of February, reaching the 23% goal, and hopefully we'll see that sustain. What's also exciting is that the green bar is increasing, and that green bar is the proportion of hospitals that are at or below the goal. We want to see that go up, so that shows that everybody is reaching the goal, or that we're working towards everybody reaching the goal. And then here on our key process measure, we can see that there's an increase in hospitals' use of the ACOG SMFM criteria for cesareans among low-risk first-time mothers. And we especially are excited to see improvement on the use of the criteria labor dystocia and induction of labor that started out below the goal of using it in 80% of NDSV cesarean sections. And that's increasing, which is bringing up our overall use of the criteria. And this is based on a sample of data. It's a random sample that we help our hospitals use to monitor their progress. Okay, doing a quick time check. Okay, I will be moving a little fast. So our next initiative I'm going to highlight briefly is our birth equity initiative. We have 86 hospitals participating in this. Really a foundational initiative. It is an obstetric initiative at this time, so it's with our obstetric hospital teams, really to build on existing hospital efforts and lay groundwork for ongoing equity work. Across all of our initiatives. And I feel like we talked a lot about inequities in maternal outcomes earlier on, so I'm going to leave it with that for now. So our aims and drivers, we're really working to get hospitals engaged in this initiative. That's our first aim, to get more than 75% of the hospitals at the table, which we've achieved. And next step is really to get more than 75% of them implementing the key strategies that we'll outline. We have 6 key strategies. They fall into the buckets in these colorful arrows below, but I'm just going to go right to the strategies. I think it's probably the most helpful at this point with time. So the key QI strategies that hospitals are working on are here. So there's more than this, but these are the ones we're really focused on. The first is to optimize race and ethnicity data collection and make sure that hospitals have the tools and the resources to review key maternal quality data by race, ethnicity, and Medicaid status to evaluate for disparities and to address those disparities. We're also working with them to implement universal social determinants of health screening using a tool, both prenatally and labor delivery. We work through hospitals, but our hospitals have been really great at extending their reach to all of their, and the obstetric side, and all of their prenatal providers as well. And we want them to have a system for helping to link them to appropriate resources. We provide tools for all these things. Just won't be able to get into them in great detail today. The third is to share respectful care practices on labor and delivery and survey patients before discharge on their care experience using a patient-reported experience measure for feedback. We want to work with hospitals to engage patients and community members to get input on quality improvement efforts. This is something we have done for years. But we continue to learn what might be most helpful to help teams accomplish this goal, and we're trying to measure improvement with this initiative on this. We also have one of our strategies is to work to help hospitals standardize their postpartum safety education and schedule early postpartum visit follow-up prior to hospital discharge. And the sixth is to help hospitals implement resources that we have available to provide respectful care and implicit bias training for all providers, nurses, and staff that touch the birthing person's experience. Okay, so this is just one example of some resources for a strategy, because those strategies each are kind of like almost a mini initiative, and I wanted to make it a little bit more clear. This is one on promoting patient-centered approaches to engage patients and communities. I have here a labor room. It's a staged labor room. It's a stock picture, but there are respectful care practices posted in the upper left-hand corner. These are something we worked with patients and clinicians to make and printed and got input from other PQCs and national leaders and posted. And so teams have these and are posting them in labor and delivery. And then they are implementing a survey that, again, informed by patients, clinicians, and other individuals we have available that they can use. They have an independent QR code for their hospital. The patient can scan it, access the survey, provide anonymous feedback, and we're working with hospitals to find effective ways to implement those tools. Also facilitating regional meetings with our hospital teams to connect them with community members that can provide insight and real-time feedback on their regional implementation of the quality improvement work. Okay, given time, I am going to skip some things. I apologize. I know it's always like a little stressful to have your speaker advance through slides, but we just don't have time probably to cover all these things. But again, you can see we use structure measures, process measures, and outcome measures for this initiative, linked specifically to the strategies I outlined. And here, this initiative has begun more recently. It is going another almost 2 years. So you do not see the type of progress you see yet on promoting vaginal birth, but you do see progress with teams in green beginning to implement or having implemented strategies, and then in yellow beginning to implement. So all great progress towards our goals of, again, implementing universal screening for social determinants of health. This is kind of all in that bucket of the steps you need to take to do that. And then here is other strategies that hospital teams are implementing already or in progress of implementing, looking at how they collect race and ethnicity data, making sure they're doing their best work there, that they're engaging community members, and that they're using, they're looking at race and ethnicity and potential discrimination as potential factors in their maternal morbidity reviews and M&Ms at their hospitals. Okay, so, and then we also see early, again, measuring all the way along. We don't have outcome measures to share today for this, but we do have the process measures here, which one example is that we are seeing hospitals engaging early in educating providers, nurses, and other staff. This is a place where many hospital teams across initiatives usually start, and we see increases in that. Okay, this is an initiative that I am likely to only give the footnotes version. It was already like, it was like Cliff Notes, now it's footnotes. This is the Babies Antibiotic Stewardship Improvement Collaborative initiative. This is our current neonatal initiative. We have 82 hospitals participating in this. The reason this matters is, so what they're doing is they're working to make sure that babies get the right antibiotics, so the right babies get the right antibiotics for the right amount of time. We know that antibiotics are essential to fight infections in newborns, but there's wide, again, we talk about this a lot in QI, wide variations in antibiotic prescribing for newborn infections, and it can lead to unnecessary or prolonged antibiotic exposure, resulting in short and long-term adverse outcomes. So that's why we're doing it. The initiative aims to decrease by 20% the number of newborns born at greater than or equal to 35 weeks gestation who receive antibiotics, and then decrease by 20% the number of newborns with a negative blood culture who receive antibiotics for longer than 36 or 48 hours. So again, that the right babies are getting it, and they're getting it for the right amount of time. So here, these are just some strategies. I'm not going to go over this full slide to respect time, but they're really looking at using the appropriate tools to assess risk for sepsis, which is why antibiotics come into the picture. Using the electronic medical records to implement protocols and practices to help providers do the right thing every time and make it easier for them. And implementing QI strategies kind of congruous with some of the stuff we talked about in the Promoting Vaginal Birth Initiative, doing timeouts, automatic stop orders, building in processes to help everybody do the right thing, right time, family education. And then what we expect to see then is, complete implementation of risk assessment calculators and tools, making sure that they have reporting available from their EMR, and that they have communication tools and stop orders in place. Okay, so the teams here are doing really great. There's a lot of progress here. This initiative goes through the end of the year. They've already achieved the goals on several of their measures, and they're working towards the others. And just again, brief highlight of how we look. This is going to be more about how we look at data than getting into the details of the data. But we can see, as a process for making sure that babies, which babies, how many babies, I guess the proportion of babies who receive antibiotics within 72 hours of life, we're trying to decrease that. And we can see that is in progress at the goal right now. And then the other another key measure is making sure that antibiotics are stopped and don't when no longer needed. And so this is showing that there's an increase in the stopping in dark green within 36 or less hours, and in the light green 48 to 36 hours. It's for both babies born 35 weeks or greater gestation, and then the babies that are born earlier at less than 35 weeks. So we can do this important work with earlier babies as well. Okay, so what we all came for. Needed the context, excited to get people involved. Lots of opportunities for different folks. So we really work to involve clinicians. So I'm speaking about clinicians in this part in both the collaborative level, so working with me and my team, as well as at the hospital level, so supporting the efforts of their hospital's quality improvement team. There are lots of ways that clinicians get engaged in our collaborative work. These are actual real pictures of people doing some of the activities, but I'll just go through them. So we have obstetric advisory work groups and neonatal advisory work groups. Membership is open based on interest. We have a lot of physicians, nurses, public health leaders, patients that participate in these advisory groups. They meet monthly to help guide the work that we do, and are really our first line group that we take our ideas to and really engage in the process. There's also opportunities, so that's kind of transcends initiatives. Advisory membership usually is something people do for a long, extended period of time across different initiatives. They're interested in the quality improvement mission overall. Clinicians that are really interested in a specific topic and are a state leader in an area can be a part of our collaborative as a clinical lead on a quality improvement initiative. So we have I don't want to use the word permanent, not sure it's the right word, but we, Dr. Ann Borders and Dr. Leslie Caldarelli and Dr. Justin Josephson are our clinical leads that, again, are with us across all of our initiatives. And then within that, working with Ann, Justin, and Leslie can be clinician leads that are specific to an initiative, and they provide lots of input into the toolkit. They help us troubleshoot issues that come up and ongoing engagement opportunities. We also have a Grand Round Speakers Bureau. This is someone, again, who's probably really interested in a specific initiative or a champion or looking for opportunities to speak to other clinicians. This is a great opportunity to be a part of a group, a list that is tapped when hospitals ask us for a Grand Rounds talk. Maybe they don't have the internal resources. Maybe they know that an outside expert would be especially valuable to them. We provide the slides from ILPQC for that to happen. Face-to-face breakout session facilitators. So I mentioned we have in-person meetings for our spring one, which is coming up in May. We call it our face-to-face. It's really our working session where it's almost all teams participating. Clinicians who are part of the collaborative can help lead the breakouts and really be a part of the discussion and addressing specific issues and coming up with specific strategies. And then we also have other opportunities for work groups, expert panels as designated. So those are all ways clinicians can be involved. We also provide resources. So if you're like, collaborative opportunities sound cool, I'm a clinician, but not sure that's what I'm looking for, kind of want to get started with my hospital. We do provide a lot of support to the hospital teams at your hospital to engage you and support you in your effort to do the quality improvement work. So we really help them build the case for the meaning of the initiative to help champions go across and spread the word about the changes and why. We help really define strategies and provide resources for the systems changes that are needed so that if you're a part of a team implementing changes, you have the resources you need to do the right thing every time. And then we provide resources to support culture change with a lot of really actionable and supportive and scalable tools for provider and nursing education. And then we really provide tools and trainings for the use of quality improvement data. So if you're really interested in data and want to think about and use and review your hospital's data, there's opportunities there. And then we also have tools for people who might be interested in reviewing cases when quality improvement or the practices aren't being implemented and providing feedback and follow-up. So if you're interested kind of exploring what initiative is about at a more practical level as a clinician or as anybody on this call, this is our website. It does have a lot of information I'm showing this image because if you go to the initiative, you go to the page, you'll get to the initiative page, you scroll down to toolkit, there's an interactive set of resources. That's probably a helpful place to start. So there's lots of benefits for participating. Really, we offer tools and resources to support implementation of evidence-based practices. The toolkit really is that. We do a lot of work to help people navigate and understand those resources on our monthly Teams calls. So the toolkit alone, if you need more, those collaborative learning webinars that happen monthly are where it's at. We also, clinicians can benefit from networking and speaking opportunities that I mentioned earlier in the slide with the honeycomb. There's also leadership opportunities to be a part of an advisory work group or as an initiative clinical lead. And then we do offer for our initiatives professional maintenance of certification Part 4 credits. So now, what about if we're not a clinician? There's a place for you. We have expanded resources over the time for really engaging patients, families, and communities specifically here. So we have a patient engagement pilot that helps our hospital teams engage patients to advise their QI work at the hospital level. So that's one way people can get involved. We do somewhat regular focus groups with patients and communities to get feedback on our initiative resources before we roll them out to our teams. We have had patients, families, and community members share stories at our large meetings. It's really an opportunity to share stories and hopefully really drive actionable change. We also have regional community engagement meetings that we've started this year with EverThrive, which is another state partner that does maternal child health programming that have really been a tool that we're working on to help connect community members with regional hospitals doing work in the area. We also participate as a collaborative level on pretty much all state agencies, work groups and task forces dealing with infant and maternal morbidity and mortality. So we really share our ideas, get input from the community in that. Okay, so we're almost wrapping up. So again, patients and families can share their stories in collaborative meetings. They can provide input on resources, both at the collaborative level or connect with the hospital and provide feedback at the hospital level if they're interested in a specific hospital near their home. They can also serve on patient advisory councils and hospital QI teams, which is what I'm describing. And then not to be left behind, as kind of a social work public health professional myself, there's opportunities for folks to serve on advisory work groups and engage in collaborative projects in lots of ways, depending on your interest. So always reach out. So I encourage all of you to connect with your hospital. If you are a clinician or a person practicing or working closely with a hospital, see if you can connect with your hospital QI team. If you need help finding them, let us know. We're happy to do that. There often are different designated team members for different initiatives, so it may be helpful to know what you're interested in clinically, or we can connect you with a really good contact at the hospital that's more broad. We also have online initiative toolkits and resources that we encourage you to take a look at. And then please connect with us. Here's our email address. We'd love to hear from you, no matter what perspective you bring. So I really want to thank everybody for their time. And I know I covered a lot. We tend to do that at ILPQC, cover a lot of ground. I know it was just a sampling, but hopefully enough to spark interest in future conversations. So thanks to all.
Great, Patty, that was wonderful. Thank you so much for sharing your work with us today. And there are a couple of questions. One comes out of the Q&A. The question is, you talked about a little of this at the end when you were talking about opportunities to get involved in some of the structure, but do you have teams addressing community-related causal factors at a community level? So as you're sort of implementing these social determinants of health screening and widening the lens for community engagement and thinking, I think about, that a lot of the disparities maybe in birth-related outcomes might relate to social determinants of health. Examples from the questioner are causes of mortality, like unhealthy habits, smoking, drug use, alcohol use. I was thinking also just access to prenatal care, et cetera. So can you talk a little bit about that and how the collaborative deals with that?
Yeah, for sure. I'd say there's a couple of pathways where we take that information and try to build on it. And our initiatives increasingly work on these areas, so we'll always be learning and sharing more. But through the State Maternal Mortality Review Committee and the Fetal Infant Review Committees, a lot of that work is spent really looking at specific cases and understanding how those factors can contribute to death and morbidity. And so we have a lot of that data that we think about as we're starting an initiative and thinking about what strategies are necessary to support change in the area. We also, I mentioned that we sit on now a lot of task forces. We really try to be a part of community task forces that have community members and learn about the challenges that folks are facing, both in specific health behaviors as well as access to healthcare and resources. And so I'd say that they factor in a couple of ways. A specific example, because I think I'm always an example person, it's helpful to understand what we're talking about. For our birth equity initiative and implementing universal social determinants of health screening, the questions that are asked are on those points often, the types of questions you're asking about. And we work to help the hospitals find that information out. So if I'm a clinician caring for a patient, that I understand the context and the factors that this individual is facing. And then we have linkages to resources through providing access to databases that help link clinicians at the hospital to resources in the community that can help support patients on those specific social determinants of health areas. So that's like the clinical level. At the collaborative level, it's learning what's happening and connecting with community-based organizations to collaborate and share information to improve how we do our work that we can do at the hospital level.
That's great. Another question, we've had a couple of recent presentations on implementation science and talked a bit about the difference in sort of frameworks and perspectives between quality initiatives, learning health initiatives, implementation science, and what those differences are. It struck me today that a lot of the examples of initiatives, past and present, that you shared are multi-pronged, sort of strategy approaches to try to improve delivery of best practices, reduce variation, improve outcomes. And are there, how do you, when you've got a bundle of potential strategies, you use huddles and onboarding new measurements and dashboards, and how do you always implement them as a package? Are they mapped to certain characteristics of the hospitals and maybe the outcomes that you're seeing? And do you ever evaluate or compare them to one another to learn more about in what context does intervention component A work better than B, for example? Is that something that's already known, or is that something that the collaborative is also involved in?
I think that's like emergent knowledge that we need to do more work in as a kind of a nationally. At ILPQC, so the first part of the question, typically we approach initiatives, all the strategies you see within an initiative together. However, there is an art to dealing with them in a certain order and pacing that implementation in response to where the hospital teams are at. And so we don't say, here are all your strategies, go forth and have fun. We say, here are strategies that we've defined. Let's make sure we all understand what they are. We're going to start here and focus, the next 1, 2, 3 months on really unpacking this, learning back from a lot of our collaborative is hearing back from the hospitals about how things are going, what they're doing, and how they implement work, because that's the most interesting to other hospitals. And then we make sure that there is understanding before we move on to another, and then we circle back a lot. So I would say that we do them all. We offer them all together, and hospitals could pick and choose where they want to start. The idea is that they will do them all, and that they will, some may be already, in progress or completed with some of them by the time they start, but for the most part, they're usually with our initiative starting from the beginning, working to implement them over time. We just pace it to meet the needs of the team. Now, looking at like what works, I mean, it is one of my main interests is after we do our analysis of, did we make significant change in these process and outcome measures over time? I really love, from a quality improvement perspective, which is what I try to bring to the team, is understanding which structure measures, so which changes are associated with better process and outcome improvements. So we have started to do that for our initiatives. I would say it lags behind understanding if we made the improvements. And we don't necessarily, I'd say with some initiatives, we know going in which strategies are going to be the biggest hitters, and we start with those and focus most of our energy on those and evaluate performance and progress mostly on those heavy hitter ones. But it's still helpful during an initiative. We're trying to do increasingly during an initiative to understand which strategies that hospitals get in place have the biggest impact on their process and outcome measure improvement. So which of those changes actually help them achieve the goal either fastest or most enduringly, or most steadily. So I think we do look at that, and there's definitely room for growth in that area.
Well, that's wonderful. It certainly sounds like there's a lot of opportunity for involvement. And I think in the chat, there was some comments about people, wanting to see that slide again for contact information. I think we're going to circulate the, recording of the presentation so people will be able to find that. And I think go to the last slide for information. Sounds like they can also go to the ILPQC.org. Are there other ways you suggest, Patty, for people who might want to be involved and learn more? To what's the single fastest way for them to get that information?
So being a person that always values that one-on-one conversation, I would advise anybody who has a specific thing that they want to talk about to reach out to us at info, so INFO, and I can put it in the chat, at ILPQC.org. We have a team. This ensures that it gets to the right person. Most of these requests will come to me, but it helps me make sure that it doesn't get lost in my inbox and it gets you to a team where we all manage it together. So I can put that in right now. Let's see if I can put it for everybody. That's probably your best way. Or we can have, if it's more of a general, like, I want to know more about this, but don't know where to go, we can direct you to specific resources. So my team can help with that as well.
Great. I think Adela just put that in there as you read it off.
Oh,
so she
put
it to everybody in the chat. So I want to thank you, Patty, for sharing all of this wonderful information with us and the opportunities through ILQPC, and thank you for sharing your after your lunch hour with us today. We really appreciate it and appreciate everything you're doing.
Yeah. Thank you for the opportunity, Dr. Ackerman. I appreciate it.
You're welcome. Take care.
Bye, everybody.